Good morning, everybody. I'm H.S. Kim from SNUH Hospital. My co-operator is Dr. J.Q. Han, and Dr. Minju Han, and Dr. Hyo-Soo Ha, and Dr. Do-yeon Hwang, Hyo-Soo Jin, Park Eun. There are many steps here to support our live demonstration. Slide, please. Okay. 60 years old male. First trial, Antegrade to LAD CTO failed 10 days ago by a young doctor. Because today's target is proximal LAD CTO with collaterals from RCA. 비춰줘야지. 그 마우스 안 비추나? 김재현 선생. 플러스 age is 60 years old. That is very important for CTO intervention. Renal function is good, plus medication. Today's target is LAD CTO. With first Antegrade trial failed, thus I start Retrograde approach. Plus X-ray ECG normal. That is also important. There is no infarction in this patient, although he has CTO. Plus echo shows normal wall motion, plus CT shows total occlusion at mid-LAD with heavily calcified CTO segment, plus Sesame SPECT shows reversible ischemia in LAD territory, plus 10 days ago, CTO PCI was tried by a young doctor. We can see on the left panel, proximal stump is blunt with side branch. That is not favorable. Cranial view is vague proximal stump. But luckily, we have a good collaterals from RCA to LAD. The problem is at the apex, we have some corkscrew structure. It looks easy, but actually very difficult to negotiate corkscrew morphology. Plus tried Antegrade. Plus it looks good. Minus yeah. But finally, my young doctor just hurried up and slightly missed the distal true lumen. In this case, distal cavity is a trifurcation. Such case, it is very difficult to puncture the true distal cap to save both branches, not only major but also side branches. Thus, in this case, the retrograde approach is a really good strategy to salvage two side branches, not only main vessel but also side branches. Plus, good things, well-developed epicardial collaterals from PDA to LAD, tapered distal stump, feasible for retrograde approach, CTO segment not long, straight, looks straight. Bad things, proximal stump, ambiguous. Second, calcified CTO segment. First trial, Antegrade, failed. Thus, let me show the today's angio, the first. 이게 처음 아까 준비를 하라고 그랬는데. Okay, today the first 아니죠?
이쪽까지.
아 참. 자, left angio, vague proximal stump with side branch. No Antegrade perfusion through ipsilateral collaterals, plus cranial view. Proximal stump is very difficult to identify, plus a little bit we can imagine CTO segment direction with calcification, plus aerocranial view, not good, plus caudal view, we can see diagonal branch at the proximal stump, plus caudal view, we can see the down downward diagonal branch. And then we can see that is probably proximal stump with side branch of diagonal. Plus, and bilateral injection, RCA, proximal RCA have a lesion, plus cranial, good collaterals, plus areocranial, good collaterals. Distal cap, many branches. Thus, it is very important to do a retrograde approach to salvage septal and diagonal 1 and diagonal 2. If you do antegrade approach and puncture at the distal part of those quadruple trifurcation area, you can obliterate 3 branches, septal and D1 and D2. The problem is at the apex there is a complicated corkscrew morphology. That is today's main theme, plus how to negotiate it. Areocaudal view, plus the most important thing is to exactly assess the 3D anatomy of those corkscrew segments with multiple different projection angles. Plus, we think areocranial view would be the best. Not the best, but next to best, because all the views cannot clarify the corkscrew morphology. Plus, then I tried Corsair Pro Access backup Xeon wire, and I advanced the wire into the PDA plus, and there are several branches. There's to and fro. Then I passed the first hurdle at mid PDA.
Can you tell me the name of the guiding catheter and the size?
Right?
Right. AL1,
Right.
short tip.
Yeah.
그냥 AL1.
AL1 side hole,
Side hole.
8 French.
8
That
French.
is important, 8 French.
French. Really.
I always use 8 French guiding catheter for retrograde approach. In this case, it may not require, but we don't know
Like how
what
about the left
hurdle
side?
happened. Left side 7 French EBU.
Same French EBU. Okay.
To expedite the progression, I just let the hairpin loop plus, and then I advanced our toughest valley,
Yeah.
corkscrew valley.
Maybe we can stop here and can discuss about the difficulties of this trial. Maybe retrograde approach is reasonable because the ambiguous entry and failed antegrade approach. Very, I don't think anybody refused to go to retrogradely. And as Dr. Kim mentioned that we will anticipate several difficulties for this procedure, and let's discuss about that, how to overcome it. Dr. Otsuji, you'd like to start?
Yes, the retrograde approach is reasonable in this case, but I have some concern about proximal myelostenosis or RCA, and also this big channel is sometimes cause ischemia. So I would like to try to check some septal branch to hold a retrograde approach first.
Actually, I cannot see a lot of good collaterals through the septal artery. So
No, no,
Because
no.
there's a
You'd
big,
like to stent
there is a
RCA?
big channel
Yeah.
that
You'd like to
made
stent RCA?
other channel was
Yeah.
suppressed. Okay, it is good point. Thus, I have to hurry up. Because I show until what I've done, and then I continue my procedure while you are talking.
Okay,
Okay.
Yeah, sure. Go ahead.
Next, plus,
Anyway, Japanese doctors usually stent RCA at this point, right?
I would like to do.
Then I advanced microcatheter
like to do
plus,
Any more difficulties, other
and
panels?
when dye injection, it is not
Comments?
true. Thus, I
How about the tortuosity, corpus-through?
Plus-
This is a large vessel, but the epicardial,
and I changed the wire to SO3.
so 3.
And tip injection, it was not really helpful. This is not one angle of tip injection plus
This is
Another angle,
Corsair's
tip
extra
injection.
small. Microcatheter is Corsair extra small.
Pro XS plus
Corsair
plus
XS, right? It's extra small. Okay.
plus. Then I changed the wire to SAW3 and try to navigate. But heartbeat make the wire into the side branch as like this. Plus. So I just make a knuckle to avoid side branch with gentle advance of microcatheter until the farthest point. Plus, then check the knuckle wire is true lumen. Plus, then I advance microcatheter and withdraw the wire to release knuckle. Plus, like this. And then I advance the wire. It already passed the most difficult valley. Here, it finally reached the plus. It safely passed the death valley, but still, an every beat make the wire slip inside branch. This,
You didn't change the wire at this time, right?
no,
Yeah. Oh,
just
surprising.
this is second wire, SO3 plus.
Second wire. After the knuckle wire technique, you changed the wire.
No,
No. Oh.
yeah, just because knuckle formation is very gentle and the tip of the SO3 is very soft. Thus, even though knuckle wire, cautious knuckle wire is not so dangerous in epicardial collaterals with such kind of size. Plus, then I reach the distal cap with SO3 wire plus minus. Then I advance microcatheter, as you can see. Then I start retrograde approach while you are talking. First wire is Gaia first.
And this is where you are now, right?
Yeah.
Okay. Yeah, we can start discussion. So, knuckle wire technique is not familiar to me. So, is it safe for this?
Not safe.
We discuss,
safe.
Not safe. We can discuss ourselves. Go ahead. Go to the procedure. So,
It depend. I think it depends on the vessel size.
yeah. Size
So
is
the-
large like this.
Yeah.
It mostly is safe. Right?
This channel is the vessel size is 1 milli or something. So, but I don't want to do knuckle.
Yeah. The who-
but
Me either. I don't like to get knuckle, but it is very difficult.
But your performance is very nice today.
So anybody agree with knuckle technique or
Ante-
retrograde approach?
I do some retrograde knuckle techniques, but not intentionally. Using SO3, sometimes it makes a spontaneous knuckle and push.
Yeah.
Then it goes into spontaneous knuckle and the microcatheter goes inside. But sometimes SO3 is very soft, so after making a knuckle, you have to retrieve the SO3 and maybe use another SO3 to go. on.
Dissection 될지
Change the
모르겠지만.
wire will save. Dr. Nakamura?
I think most important point is the definition, the thinking way about the knuckle. So this knuckle is very nice because of this knuckle stabilize the position of the chip of the wire and then advancing the tube catheter. So this is a nice way. We sometimes go to to chip the wire going to some branches. But
Cranial,
this,
okay.
this knuckle, it
So you
makes
use
it
the
stabilize.
knuckle technique intentionally sometimes to avoid the branch, right?
This is I don't use, but this is nice. Anyways,
This is nice,
and
nice.
because I stabilize the wire position, and then can advance
괜찮아요.
excess.
Actually, I like to change the
아일랜드를
wire
아이덴티파이
for the safety, actually. So, but he was successful.
Safety is depend on the
여기
operator skill.
사이로크라니얼 한번 가릴까? 약간 LA 한번
So,
줄까?
other comments
LA.
about the procedure? Actually, I'm worrying about the
한테 한번
disease in the
살짝
proximal
보시죠.
LED
아래
osteum.
잠깐만.
The severely stenosed and the target is very small, even retrogradely, right? This make and calcified also.
카우달 줄 거예요.
But this case, we can see some retrograde flow into the CTO.
자, 여기서 안테 살짝 하면
So
됩니다.
the ring length is not so long, less than
Right?
15.
Yeah, yeah. But target is small.
Yeah, when you see this image, the CTO segment is more than 2 centimeters.
Yeah.
Yeah.
Because we can see definitely proximal cap and distal cap. Okay?
So I'm worrying about the
그냥
severe
그렇구나.
stenosis in the LED. Then makes the wire can go to the plaque into the left main.
마이너스.
That it'll make us some problems. So
You mean the retrograde wire?
the wire can go to the proximal LED also plaque into the left main plaque. So intimately, because it's a very small
It's in
target.
the case of the retrograde direct crossing. So we should check the retrograde entry point if we apply the retrograde direct crossing. So the wire go to the reach the
크라니얼에서 댄스하고 카우달에서 디렉션
LED
크라니얼.
proximal side. We should check the angiography.
Right, of course. Yeah.
And also, sometimes we enter the antegrade wire or the target to the retrograde
Right,
wire,
right.
like kissing.
그렇죠? 그거
Yeah, but so actually the main point of this kind of procedure is that we need to control the inside of the CTO. So from the retro anterior, then this is a very nice, the picture. Now we have a pincer movement from the retro anterior, and we need to control the inside of the CTO so we can finish 100%.
So Dr. Kim, what wire are you using now?
가야 first.
Gaia first. Okay. So actually, it's a tapered wire.
may be
and, do you,
other
anyone
direction.
prefer non-tapered wire at this moment? Tapered wire is better.
Because the distal side are a little bit tapered, I think. So in this case, I also choose Gaia next one.
Next one, right? Yeah.
But some severe calcification there, so maybe we need
Why the wire
wire
deflect
escalation.
for the diagonal side? Yeah. Because of the previously, the CTO tissue is destroyed 10 days ago.
Yeah.
Okay, Gaia second.
It's calcified. Yeah, calcified, and actually, still we don't know where the proximal entry of the CTO, right?
Yes, but if the Gaia wire reach close to the proximal end, we can see the target.
Antegrade wire.
Yeah.
diagonal 쪽으로 세는 이유는 뭐지? 팁이? 거기 브랜치가 있는 게 아닐 텐데. 자, 빼고요.
Kim says no ST change now. ECG
No.
okay?
He is very strong.
Yeah, okay.
No complaint, just relax and
Okay,
comfortable.
Okay,
and blood
okay.
pressure, heart rate.
Yeah,
wonderful.
okay.
But I try to expedite the procedure.
Yes.
Many times we ignore the ischemia and the chest pain during the retrograde approach, but sometimes chest pain complaint, patient complain chest pain, CKMB rise I checked the MRI, and surprisingly, I can find the infarction in the around the septal channel.
Really?
Yeah, but ignored many times.
A little bit advanced. Kaya second. Then I checked the direction at the AP caudal, aerial caudal or AP caudal.
Maybe you need to insert the wire from the left guiding.
Yeah.
It may help the
From
target.
now on, I'd like to do. 빨리 카우달 해달라는데 뭐하노? 자, 와이어 줍시다. 자, 안테, 라이어 first. 아까 쓴 거 있죠? 그거 쓰면 될 것 같은데.
Actually, wire progress is not easy now. So
그걸 마이크로
Dr.
나가서.
Kim says in Korean, says that the wire is diverted to a diagonal, not into the plaque. Why is that? Or how to overcome this problem?
So he already changed the wire to Gaia next to.
Next to
Yeah.
a strong wire. Okay.
뭐 장전했어요? So I prepare the anti-wire Gaia first that I used just before to save the wire used number because the TV is okay. To save time, I manipulate retro wire while anti-wire preparation. The progression direction is not good. Okay.
How about checking the areocranial view?
와이어 스틱 하고요. 자, 테스트 잘 안 보이는데, 그치? 자, 와이 아직 안 나왔어? 많이 들어갔다.
I'd like to hear some discussion from the panel members to help Dr. Kim. Mike Lee, anything to say?
테스트 준비.
I mean, I would typically in this situation go to a straight AP cranial 40. It just gives you a better directionality,
AP
a progression, and a projection, where I think where the osteal LAD would be. So, and also I would mag it like you just did right now. So just the projection is not a typical. It was demagnified. It was an REO projection. So I want to go straight 40 AP cranial. Just gives you a better projection.
Maybe changing the view may help.
카우달 봐야 될까? 카우달 봐야겠네.
Dr. Kim goes caudal and Mike Lee suggests the cranial.
No,
It depends.
he now manipulating the antegrade wire. So the retrograde wire.
Antegrade wire. So wire seems to be in the circumference, right?
Yes, because he used, I think he used EBU, maybe the directed the circumflex.
In that
The
case,
guiding
actually,
catheter. So
the deep engagement with counterclockwise rotation may help
Yeah.
to direct the wire to the LED.
자, spider view.
Yes,
Spider view is
spider,
helpful.
yeah.
Spider view is best.
테스트.
And in this view, just look. It's okay. He's working with the antegrade wire now.
야. 뭐야?
So, Dr. Kim, you have 3 minutes.
오케이.
Okay. Oh, enter the LED now.
안 보인다. Change our cath lab from number 2 room to number 1. 그래서 그 마이크로 카테터가 어디 있지? 아직 안 나오진 않았겠지만 어디쯤 있는지도 안 보이지. 참, 어이가 없네. 오케이, 카우달 뷰. Then I put the anti-wire into the proximal stump. Then that is a target for the retrograde wire. 좀 돌려봐. 가리잖아. 더. 오케이. 자, 안테 한번 테스트 해볼까요?
There are two expertised operators, so in this situation, simultaneous approach, retro and antegrade, might be helpful.
I advanced retro microcatheter for the better maneuverability of retro wire. 말리네. 칼슘이 심하네. 가야.
Why don't you use microcatheter in antegrade approach?
I tried to focus on retro because ante was failed 10 days ago. Of course, if retro advance is not good, I try ante approach, both grade, because I think now wire enters proximal stump, right?
How about checking auriocranial view?
Wait a minute.
Okay.
가야 third로 바꿔야겠네. 가야 third. 자, 안테 마이크로 카테터를 쭉 어드밴스 해야 되는데 안 보여서 지금 문제인데 자, 잘 봐. 너무 넣으면 Y가 prolapse 되거든.
So, Dr. Igarashi, can you change to Seoul and come back with you after 12 minutes?
Please go Seoul National University,
Okay,
and later
okay. Thank
I will show you
So,
the.
Yeah, I'm very happy to see that antegrade approach, and you are changing to a retrograde, right?
Yes, just now.
Okay, we'll come back in 12 minutes.
Okay.
Dr. Kim, Seoul National University, please.
Yeah.
Yeah. How was the progress?
We retro wire reached the proximal cap, but a little bit out of plane. Thus, I tried to make a new pathway by drilling with other direction. But the calcium is surrounded by the CTO segment. It is very hard to redirect the retro wire. As you can see, that is close to each other, but anyway, final angel always show retro wire tip is a little bit out of the proximal LAD. Thus, I tried to make drilling in many directions.
So what wire are you working
Wire
on?
third is effective, but the direction in the midst of calcium is difficult. Thus, I changed to Miracle 6
Miracle 6.
to make some change.
How about
As you
contrast?
can see, there is just
Cuspid region. How about
3 or
retrograde
5
cusp?
millimeter distance, but calcium surrounds the wall, and there are 2 barriers between 2 wires. Thus, it is very difficult to
Yeah. Reverse current
Yeah.
will be very difficult because of the calcium, right?
But in that session, I'd like to manipulate the antegrade wire to reach the retrograde wire.
Yeah.
Because
here is a good
distally.
direction.
Reverse current.
But
Okay.
okay, counter view.
But now the wire direction is
proximal
very
view
close.
looks okay.
Yeah.
예상했고. Hi, here, counter view separated. That is
Yeah.
and the problem. Thus,
But,
we would like to balloon proximal part to do reverse cut, but my concern is proximal stop is really right one. That's my concern. But anyway, I guess test can be test. I think that proximal wire should be a true lumen. Thus, to save the time, I may do proximal ballooning for reverse cut. Until then, I try to my best to negotiate the retro wire through the calcified CTO segment.
Can you show the epicranial view? Because to assess the relative position of the wire, if I remember correctly, the first try, the previous 10 days ago, the LED wire was into LED up to the mid LED. Not just not this. Sure, if
Okay,
the wires are okay,
the cranial view.
the wire is in the wrong side of calcium, I think. So
I think we can see the calcium. Thus, I think the proximal wire may be around the calcified segment, but it is not advanced. Proximal wire is Gaia first.
And retrograde
There's,
wire is
Miracle 6 now.
Miracle 6. Okay, right. Miracle 6, Gaia first.
And finally, I would like to challenge Conquest Pro as a retro wire to break the calcium.
Sometimes, many times we think 3D reconstruction of the position of the wire and the plex. So we,
Okay, Conquest Pro.
anybody prefers a different view at this time?
We need, I think that this time the areocranial and the caudal is orthogonal view. So you can estimate the CT. So to what is the optimal view for angiography?
At least we need two views. Yeah, Dr. Mike Lee?
Yeah, I would actually even go more AP cranial because there's less foreshortening. So at least
Right.
40 would be very helpful. Number two, this is just a thought. Is 10 days too early to bring this patient back? If you had a failed CTO, I think
Yeah,
maybe waiting a month to wait for healing. But I understand there is time sensitive. We have a case to do in a
But he
Yeah.
was planning a retrograde, so the 10 days not a problem, I think.
But the previous time the guide wire go into the subintima.
Yeah,
So it's
subintima,
okay.
right. Yeah.
For retrograde.
Retrograde.
Because the previous time the wire go to the diagonal.
Yeah,
Past the
and the past,
Not
I think it
diagonal,
passed
just around the diagonal.
around diagonal. Just
The
go
force
to, follow the way until the mid LED, I think. Dr. Kim, did you change the wire or
Yeah,
reshape?
Conquest Pro to
Conquest Pro, right?
to break the calcium.
Yeah.
And that try will be
Conquest Pro-
3 or soft wire.
Conquest Pro or Pro 12? Just Pro?
Pro 12,
Pro 12? Okay.
잘 안 보이네.
Maybe you can check the epicranial or a different view to the direction of the wire and the relative position of the antegrade and retrograde wire.
First, this is areocranial, then I always checked areocaudal. Okay, check areocaudal.
How about epicranial? No?
In this side, areocranial areocaudal is the best, I think. Dr. Orang, what do you think?
Areocranial and areocaudal is best perpendicular direction because the proximal part, this coronary is a horizontal running. So that's why areocranial. Areocaudal, maybe areo 45, caudal 30,
Horizontal.
areocranial 30, RO 30, cranial 30 around.
So the epicorder is the best. I think the epicorder is best for the mid LAD.
오케이, 안테를 조금 우리가 바꿔볼까? 안테 리트로가 false lumen.
네.
Yeah. Dr. Otsuji recommended the further progress that push the antegrade wire further down the mid LED. You can make a reverse current in the mid LED. Right, Dr. Otsuji?
Yeah, I would like to advance the antegrade wire more distally. Because antegrade wire is the maneuverability is better than retrograde wire, so.
안테 있어, 오케이. 자, 아이어 크라니알요 줘볼까요? 자, 안테를 아까 가야 세컨드로 줘볼까?
So why not make a knuckle here? Retrograde, antegrade, remove the proximal and distal cap ambiguity, and get your wires closer to you so you can do the reverse cart.
Yeah, also
Wire knuckle.
yeah, distal wire knuckle
Knuckle.
and to the target. We
That
could,
is good idea.
Yeah,
I mean, I think
manipulate the antegrade
Fielder
wire.
XT retrograde here removes the cap ambiguity completely. You'll probably be able to get around the calcium because you've spent a considerable amount of time trying to stay true lumen to stay inside the calcium, but that's you're really not getting there. So maybe then a knuckle here is gonna help.
오케이. knuckle, anti-wire knuckling. 아이고, diagonal. Because previously there is a kind of damage 10 days ago. It's a little bit wrong way. Lydia?
I really like to see the
오케이.
LEO or
자,
epigrade.
주저하고 크라니아, 카우다운. How about this?
Yeah. So
Looks good. 주저하고. 엘레오 크라니아? 오케이, 에러 크라니아.
and you may want to consider using a guide extension catheter in your antegrade guide to make sure you don't come into the left main. So like a 6 French guide extension catheter pushed into your proximal LAD will help you make the connection inside that space. And then you have a targeted amount of plaque where you can try to re-enter and do your connection.
That's okay, areal cranial. Direction would be acceptable. Thus, I would like to advance microcatheter, anti-microcatheter. Then I release
And so maybe you want to try bring your retrograde microcatheter up and do the same thing with the hydrophilic wire, because making the connection in this part of the LED is going to be a lot harder.
하고요.
So we need a
How about-
retrograde wire to be overlapping in the plaque using a hydrophilic wire, and use, like, say, example the same in XT
그다음하고-
retrograde.
자, 우리 리트로 인젝션 해볼까요?
No, but the already knuckle wire is go to the subintima, so I think it's time to reverse cut.
But I think your antegrade wire is in
I
the
would like to check the tip injection from retrograde.
Yeah, so, but to make the connection, you need to be in the plaque, right? If
Yeah.
you're in the subintimal space above the true lumen, it will be very, very difficult to connect.
So in that situation, the ballooning in that CTO region is make a connection from the retrograde wire.
Yeah, that's not
Yeah.
bad. That's not bad.
아니야.
Great.
Yeah, good.
That I'd like to relieve the knuckle to enter the anti-wire into the true lumen.
Maybe check in another view. I don't think
Yeah.
so. It's unlikely.
Definitely another view.
Yes.
Okay, yeah. I like this view. Yeah.
I think
Very
it's
nice.
outside still.
Are you Ukrainian? Yeah, of course it's the outside.
Not good?
자, are you Ukrainian?
It's okay. It's okay. But I'd like to balloning in the CTO.
Are you Ukrainian?
Yeah, sure. Yeah, for reverse cut.
Yes.
Yeah.
Because Antegrade may be possible, but Antegrade rewiring
좋아요.
to
UB3.
lumen is sometimes difficult.
Yeah. But Dr. Kim, you are trying to go to true lumen at this moment, integratedly, or just a reverse cut?
I'd like to do reverse card.
Okay. It's more predictable, right? Yeah. So, Dr. Kim, actually, time is up, but I'm not sure. Do you want more minutes? It's quite impressive. The knuckle wire technique is is working here.
So I think you need to integrate balloon here, and you'll have a
Right.
connection in this space. This is actually very promising.
Yeah.
Okay.
Yeah, I think Dr. Kim is planning the reverse cut, the ballooning integratedly and puncture with a retrograde wire. Right?
오케이. 자, 물론 해볼까 우리? 조금 더 안 태우 그거를 좀 더 넣고 할까? 마이크 카테터를. 오케이.
Maybe check that in a different view to see if the wires are overlapping, but this is starting to look good.
We did anti-ballooning, but 좀 계속 틀어봐. I tried to negotiate retro wire, but that is not easy. Thus, I did retro tip injection. Because we can see the anti-knuckle wire pathway is below, a little bit far below the lumen, as you can see.
Yeah.
Did you see?
Yeah, I can. We are watching
see.
it.
Okay, thus I just try to reinsert retro wire into the true pathways with Sion. 저기 그거야? 아, 참 잡아달라 그러는데. 맵을 잡아줘야지. 오케이, 스톱.
Yeah. Yeah,
Okay,
looks
this
nice.
is true
Looks nice.
pathway. Thus, I advanced retro microcatheter until this pathway. And how about retro-knuckle wire technique?
Yeah.
Still,
It's a good way, I think.
Good way?
Yeah.
Not sure, but I tried to negotiate the retro wire.
Okay.
From here, we changed the wire to B3.
Because the microcatheter advanced much than before.
Yeah. So this is the right pathway, at least retro microcatheter.
Little microcatheter and antimicrocatheter very close this point. So
How do you think about checking IVUS in the proximal site right now? Maybe you can see the wire coming into the proximal CTO cap by IVUS, I think.
But I expect what the IVUS show. We can expect. Yes, I don't like IVUS because of time consumed. Here is a little bit dark.
Dr. Kim,
Yeah.
because you are very close to the Antegrade wire.
Yeah.
So how about change the retrograde wire more stiffer one?
If one, thus I'd like to use UB3.
Now you use UB3.
No, this is Sion.
Sion.
Yeah.
Still, we have a big diagonal branch coming in the way of Westcott. Dr. Kim, I hate to leave you now because your time is up and 1 minute passed. So we'll come back when you're after the
I would like to
live demonstration.
to the
Antegrade wire.
Did you enjoy?
Yeah, we enjoyed it.
Thank you.
It looks dangerous.
It's better than just simple success.
but the lateral wire, the route is very correct. So
Yeah, it's promising.
Yeah. Okay, it's very interesting that its time is up, and I'll let conclude this session, and I'd like to see the result in the next live demonstration. Thank you for the comments and the presentation and demonstration.
Yes, to show that coronary angio is better for this channel. Okay, being prepared for the angiography, I will show you the CTO case.
Go ahead.
Yeah, this is the end image of the previous live demonstration. So I performed the wire reverse cart, the antegrade wire knuckle and advanced, but it was wrong. Thus, we got to know the retrograde tip injection plus. Then I redirect retrograde wire to the calcified CTO segment plus. But it's very calcified, thus it is impossible to UB3, Miracle 6. Then I finally chose Gaia 3rd plus near to antegrade wire plus. Then finally entered antegrade guiding catheter plus. Then externalization and anti-ballooning plus. This is angio after anti-ballooning plus. We were able to save big OM and septal branches because of retrograde approach plus. This is final angio after 3 stenting from LAD to distal plus. We were able to save the large diagonal branch and septal branches plus. Then after removal of vitro microcatheter, we assured the safety of corkscrew epicardial collaterals. 3.5? 야, 이게 안 된다, 그지? 이걸 들어가. 뒤로 해야 돼, 보통. 오케이. I will show you the coronary angiography